Welcome to another episode of the Car Injury Doctors Network. I'm Dr. Paul, and again, the Car Injury Doctor Network is a group of doctors specifically trained not only for the diagnostics and therapeutics of the patient, but also the proper documentation to support a unfair, bad faith lowball offer. And so we go into what's called high sensitivity documentation, high relevancy documentation. And so the topic today is a real important topic, and we're going to go into basically it's the documentation necessary to support the pain portion of the injury award, and it certainly deserves more than 20 minutes, but let's go ahead and give the outline of how this would work. Again, I'm Dr. Paul. I've opened 77 offices in 20 states, authored 10 books, speaker in 3 chiropractic colleges, and I teach personal injury documentation to chiropractors and doctors, and deposition and trial testimony across the United States. So, having said that, let's go into how this works. So let's start from the end first. So remember there's 4 potential injury awards: medical, impairment, pain and suffering, and the prognosis. So we have 4 potential injury awards based on the doctor's documentation. Now let's break that down a little more and go, the 2 most important categories out of this is, was there a permanent impairment, and how did it cause pain or restrictions with the activities of daily living? That's the absolute pinnacle of the injury award. So you have the medicals, if you have the impairment, then that box can be checked. If you have pain and suffering, the documentation can check that box. And you can't have a prognosis and need for future care if you don't have an impairment. So having said that, let's go into this component. So we said the impairment's important, ADLs. Let's focus on the pain portion of the activities of daily living, okay? And the documentation, how we do that. Now, how we would do it is like layering. I always look at it like a pyramid, with the impairment and the pain and restrictions of ADLs at the top of the pyramid. And then we're layering. The documentation gets repetitive layering that all focuses in the same direction. So that's a real simple way of thinking about it. And we're going to pay attention to some major concepts here. Number 1, it's based, the pain that a patient receives and the permanent pain patient receives is based on the science of the 3 phases of healing. Number 1. Number 2, the patient does have to reach MMI, maximum medical improvement, because that's when you can give the impairment rating. In other words, now it's permanent the rest of that person's life. In other words, we heal wrong. Sure, we heal, but we heal wrong. And of course, that's what the physician's goal is try to not only abate the symptoms, signs and symptoms, but restore the function as much as possible and not heal wrong. So having said that, and then the ADLs are important. Okay, so here's what really gets to be important with the documentation. We're going to go into why the patients have pain, with activities of daily living that are permanent after injuries. And then we're going to go into the supportive document that is necessary to support that pain. And because obviously the pain is abstract. So let's go into all the layers of how we can support that, or how it's supported, or the documentation that's supported, okay? Having said that, when we have injuries, our bodies go through 3 phases of healing. And there's 3 significant things that happen to the nerves. Number 1, there's an increase in the number of nerves. That's called hyperinnervation, reinnervation. Number 2, the nerves are more sensitive. They fire at a lower threshold. And number 3, the nerves can get trapped in scar tissue. There's a 4th component called psychogenic, and that's more like the phantom limb pain theory. But let's stick with injuries, major and minor traumas, and let's stick with those 4 components. And obviously, from a physician standpoint, our goal is to minimize those and get them back to normal. Otherwise, the patient does heal wrong with permanent pain to some degree. So here we go. Let's go to, and then we're going to look at the documentation that we needed. So here's what happens is when the patient heals wrong and there's increase in the number of peripheral nerves, the regenerative nerves in that area, what happens is, if you can think of it like, it's a confined area, and what happens is when the patients move with their ranges of motion, that area gets more stretched and compressed. If I flex, I'm going to have more compression in the front, more stretching and compression in the back of the tissues. So if you think of it like there's a certain number of nerves in that compartment, when the patient moves with ranges of motion relative to activities of daily living, the more they move, the more compressive forces are. So it elongates, so it stretches, and or it compresses. Okay, so if it's on the back side, if I'm bending forward, it's going to elongate. Well, that'll narrow the area volume where those nerves are. Well, just by pure physical compression, when you already have an increase in the number of nerves, just that alone will fire the nerves sooner, just because there's an increase in number, as opposed to a simple example is, let's say I've only have 5 nerve fibers and I move a certain direction prior to the injury and I have no pain or restrictions. Now afterwards I have 100 in the same area, so that's real crowded. And then I'm trying to move the same way, and now I have stretching, which will compress it, and compression. Well, now I'm going to have mechanical compression on those nerves. That's one source of pain. Number 2 is there's an increase in the number of nerves. It's called hyperinnervation, reinnervation. And by the way, all of these are relative to the magnitude of what we're talking about and the degree of compression or stretching. So it's not black or white. Okay, so let's go to the next one, which is the number of nerves. There's an increase in the number of nerves called hyperinnervation, reinnervation. They go into that same area. So actually, we're talking about increase. We already talked about the increase in the, increase number. Let's go into the nerve sensitivity. So the nerves so there's already an increase in the number of nerves, and they're more sensitive. That's how these nerves regenerate. And we know that. We've injured ourselves before, and you touch it, it's more sensitive like that. A lot of times, and most of the time, it heals and it's not more sensitive, and a lot of times it doesn't. So it has a lower threshold before it fires. So what does that mean to the patient? So let's look at that tissue again. So it's a confined area. Now again, if we're dormant, we won't feel that pain unless it's a type C type of pain. So there's type A, acute, and type C, chronic. So you can not move and have pain. That's a different neural pathway. It's type C firing, chronic. Now this is going to be more type A nerve firing. And so what happens is, so we have an increased number of nerves, and they're all more sensitive. They fire quicker. So let's do the same motion again. So let's say in the front side, we bend. We're going to compress more of the tissues in the front side. On the back side of that movement, with that activity of daily living, when it elongates, it'll compress that square area. It'll stretch it and compress it. And so when you compress those nerves, again, it's physical compression of those nerves that get them to fire, and they fire at a lower threshold. So here's an example again. So saying the patient, and we're just kind of being really simple about this. So let's say the patient has 5 nerves in that area, and they were able to go through all 3 ranges of motion, active, passive, and overreaction, no pain, okay? And that's how it should be. But now there's 100, not 5, there's 100, and it's the same area. And they're more sensitive. So now when I start moving, I may not have any pain at all, first 5, 10, 20, 30 degrees, because there's not as much compression. And the more compression, the more elasticity or compression that happens, then it creates more mechanical forces. Those mechanical forces stimulate the nerve firing that fire at a lower rate. So that's what happens with nerve sensitivity. That's why somebody can be like pain-free and maybe move in active range of motion a pretty good amount, 20, 30 degrees or 40, especially with these low impact soft tissue spinal injuries. They heal typically normal in the non-plane of injury. Usually it's the plane of injury. It's that last active range of motion, overpressure joint motion, usually that's the motion that ends up healing wrong and permanent, causing pain. So if we don't go into it, so let's say there's not too much compressive or elastic forces, let's say it's a back injury and I bend forward, maybe I can go 20, 30 degrees, no problem. But by the time I get to 50 degrees, somewhere around that range, I've got much more compressive forces going on than the first 5 degrees. And that's why there can be no pain at 5 or 10 degrees. And then you start to feel it more and more and more as the compression increases, because you remember you have an increase in the number of nerves. So there's a higher likelihood of them being mechanically compressed, and they fire at a lower threshold. So that's what's going on with movement and pain and healing. Now, the third category is these nerves get trapped. And what happens, or there's a potential for the nerves to get trapped, and that's one of the reasons, actually that's a main reason that physical medicine is required to help minimize that likelihood. So what happens is the body heals with scar tissue. Well, that's type 3 collagen protein versus type 1. And what happens is when that collagen is laid down, it's laid down randomly. It's not in the linear lines of stress. So it's like a matrix. It's just laying it down randomly. Now, part of the therapeutic protocol, and that's why physical medicine and active rehabilitation is important in all three ranges of motion, active, passive, and joint, because when that happens during the repair phase, it helps to align those collagen fibers, which help increase the strength and elasticity, but it also decreases the likelihood of those peripheral nerves getting trapped. Because what happens is when that matrix is laying down, that collagen is being laid down randomly. Remember, we're already dealing with an increase in the number of nerves, hyperinnervation, reinnervation. Now we're dealing with low sensitivity, low firing nerves, so they fire quicker, and now they kind of get trapped in there. Matter of fact, what I'm sharing with you is the number one cause of failed back surgery. That's why the surgeons try to go for less and less incisive incisions to significantly decrease this mechanism I'm going over right now, which is scar tissue trapping the nerves, causing pain. And so what happens is when the person moves, in other words, if it heals wrong like this, that matrix. So now you have these little peripheral nerves within the matrix. There's an increased number, and they fire at a lower rate. But they're trapped. Now what happens when we move, that matrix starts expanding and contract. It elongates and contracts for the movement. Well, if those peripheral nerves are in that collagen matrix, when we move, it compresses them. And once again, we have physical compression, and this time it's from the scar tissue, type 3 collagen that's healed wrong. That's what's happened. So those are the three most common sources of pain. And once again, we're talking about chronic, acute nerve fibers. And this is how it directly relates to movement. So again, if I don't have a lot of extra nerves, if they're not as sensitive, and there's not as many trapped, hopefully the patient can go through all ranges of motion with activities of living with no pain. If some of these effects are occurring, they'll be able to move greater with their activities of living with no pain until there's more compressive forces, which is typically at the end of range of motion. This is why it's so important the doctors document all three ranges of motion and not only active range of motion. And unfortunately, doctors who have not been trained in personal injury, high sensitivity, high relevancy documentation, they don't do this. And so they miss it. They'll just measure active range of motion. And that'll typically be somewhat normal. It's that overpressure. Well, it's the overpressure that creates the most compressive forces. So we're stressing the tissue at its absolute maximum capacity within a normal range of motion. And that's why the patient can't do it. So maybe they can go 10, 5, 10, 20 degrees, and maybe at 35, 40, or 45, or 50, it starts getting more painful until they have to stop. They can't go into that full plane of motion with that activity of daily living. Okay, so that's the physiology behind it. How's it supported? All right, well, remember we've got 7 major categories of documentation that's necessary to support any case. So do we have a mechanism of injury directly related to the injury? In other words, a cause and effect relationship, and that's one of the most important findings in the consultation is the mechanism of injury. That pretty much tells the injury. The diagnostics in the physical exam essentially determine the extent or the magnitude. Next is you have subjective findings. Well, those are the least trustful, but what we're looking for are what's called primary and secondary findings that are subjective. In other words, if the patient had a neck injury, does it correlate? Let's say they were hit from the side. That was the mechanism of injury or the plane of motion. Let's say it was left lateral bending, okay? That's the problem. That's the range of motion that's going to clear up last or end up with a permanent problem to the highest degree. So now you have subject. So we want to see, if we're going to document this and support it, then we want to see subjective finds that directly correlate with that area of the anatomy, number one. Number two, the motion of that anatomy. And a lot of times what's important to help distinguish this is that they don't have pain in the opposite directions of that plane of motion of injury. See, that increases the credibility of that plane of motion of an injury. And that's usually what happens. And so that's a major factor. And then the next one we want to consider is the hybrid findings. Remember, this is like a pyramid. We're laying it to get to that one of the major components. And so now the hybrid findings, we want the same thing. We want primary findings with secondary findings are directly related. So as an example in the neck, if we have joints related, a hybrid finding would be an orthopedic test called a foraminal compression test. In other words, that is very specific, that isolates the joints and that lesion. That's primary. Now there's other tests that are called secondary that are not highly specific for that, but they involve that area or other areas. That's the difference between primary and secondary. So we always want primary, primary. Same with a disc. A disc has very specific orthopedic tests that are more positive for a disc than maybe for a joint. So those are called hybrid finding. Hybrid finding is the patient's action or reaction and the doctor's interpretation. So now you're dealing with two people, that's why it's called hybrid. So it's another layer, and we'd like to see what are called primary findings that are directly associated with the mechanism of injury and the subjective finding. Then we go to objective findings, and of course that's the big one. That gives the most trust. And then we will correlate the objective findings. Now in a low impact soft tissue spinal injury, there's 14 highly probable objective findings. 7 of them are what are called primary, and 7 of them are what are called secondary. But there's 14 100% objective findings. So I'll give you an example of a few. Let's stick with the injury in the neck, and let's say that we have a joint injury in the neck or a disc injury in the neck. Well, we're going to see the high potential of ligamentous lesions. Well, we're going to be able to document if that ligament is torn to some degree by motion x-rays, having the patient, in other words, we have the patient move in each of the directions as much as possible. We take the x-ray and we measure them. Are these bones staying together like they should? Are they moving? Are they sliding or angulating, sliding or translating, sliding or angulating further than what they should? In other words, that's the number one indication we have micro lesions in the ligament, because it's the ligaments that hold the bones together. So if they're not being held together, then of course we associate the mechanism of injury with all the findings, but that is a direct correlation. That's a 100% objective finding, primary, for those lesions. Just like there's very specific tests like an MRI for the disc. Okay, so same thing, you can have muscle weakness, which is very common, and then also you can have abnormal muscular firing. That is very common, and now we have objective findings to measure that. So we have diagnostic tools that are medically accepted, that are 100% objective. And what we do is we put pads on the patient. We have them move forward several times, backward several times. In other words, we have them move in all the directions. And it collects when the muscles are firing and how much they're firing. Well, we already know what normal should be when a patient bends forward. In other words, we already know what the arc of muscle firing should be. Well, that's not what happens when we have pathologies of altered pathological spinal biomechanics due to disc lesions, ligamentous lesions. It causes erratic firing. Well, that's captured, and it's graphed. So it's a visual, and it's 100%. It's 100% medically accepted, and it's 100% objective, and it directly correlates to that injury. So you've got X-rays. We can measure the electrical synapse. We've got, and we're only talking about the objective category. We got muscle weakness. That's a hybrid category, but it's a very important category. And then blood test. When we have these lesions, we'll typically have inflammation in the body. Now, it's not directly related, it's not primary. So in other words, just because we have a positive blood test for inflammation doesn't mean we have a disc bulge or a ligamentous lesion. But what it does is it corresponds to all these other layers: mechanism of injury, subjective findings, hybrid findings, objective findings. In other words, everything's pointing in the same direction, and it's layer after layer. That's the documentation that's necessary and required. And that's how pain, the documentation necessary to support the pain component, and that's real important. Why is that real important? So there's how, and then of course when we have those, so now we have mechanism of injury, subjective, hybrid, and objective. Now we want to make sure the patient's at MMI. That means it's permanent. Well, once it's permanent, in other words, they've healed wrong. Now that's based on the science of the 3 phases of healing. That's not in, science of the 3 phases of healing is not even in dispute. That's just accepted of how we heal. And then, so the next category is going to be MMI, and then that takes us to the impairment. So now we go to the AMA guides, so we can go into the guides, and it'll tell us the degree of an impairment. Well, how important is all this stuff? Well, the 2 most important categories for the injury award is, was there a permanent impairment after that injury, and what was it quantified as with a third-party trusted source, the AMA guides. So it's objective, it's quantifiable, and it's third-party trusted source. This is how it all comes together to support the single category of pain. And so the next category after that is, so we got the impairment, we got MMI, the impairment. The last one is the prognosis and need for future care. Remember, you can't have a prognosis and need for future care if you don't have a permanent impairment. So there you go. Now that's what happens with a lot of these injuries. They have ligamentous lesions, disc lesion, whatever it is. So you can have all these tests when you have highly trained doctors in what's called high sensitivity, high specificity, medically accepted documentation. And that's not trained in, when you typically go to medical school or chiropractic college. And especially with your specialty, you go to the emergency room, they're pretty much not going to do anything. They're just going to make sure you're not bleeding to death and you're breathing. So they're just going to do the test to make that happen. So it depends on what doctor. You go to a pain doctor, he's just going to focus on treating the pain. You go to a GP, they're just going to give medication. So they won't even do these diagnostic tests. Same with most physicians, unless they're trained in high sensitivity, high relevancy documentation. And that's what's required that's what really should be done for all diagnostics, because it's the best. It's when you pick up the most and you quantify it the best. And that tells us if the patient's getting better, worse, staying the same, or ends up with a permanent injury to some degree. So there you have it. That's the short version of the documentation that's used for high sensitivity, high relevancy. And then we now measure, we quantify the patient's activities of daily living, and we evaluate them they're evaluated in all 3 ranges of motion: active, passive, and joint motion. The joint motion is evaluated with X-rays. Active range of motion, remember, is usually normal. If something remains positive and permanent and active, it's usually only the plane of injury, and it's usually the last 5 or 10 degrees. The real injury is in the overpressure joint motion, and that's where most diagnostic tests are not done. That's where the doctor has to know high sensitivity, high relevancy documentation as opposed to what I call low sensitivity documentation, like active range of motion, reflexes, dermatones, things like that. Those are almost always negative for the most part. So that's the documentation that's necessary to support the pain component for the injury award. It's based on the science of the 3 phases of healing. It's based on mechanism of injury, subjective, hybrid, and objective findings, primary and secondary. That layer that all just build, and keep pointing to, yeah, that's obviously it right there. That's what's causing the pain. That's how it works. For more information, contact your local car injury doctor network provider, and they can go into greater detail with this. This is real important information because it's one of the major components of an injury award, which is the pain component. Having a doctor that not only can document it, but explain it, and then relate it specifically to that patient's injury, and that patient's activities of daily living with that plane of motion and all 3 ranges of motion. That's when you stop unfair, bad faith, lowball offers. Contact your local car injury doctor network provider for more information, and we'll see you on the next episode.